The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this month to be able to welcome back a guest who we've had on before, Dr. Shawn Mendenhall, a hand surgeon and a delightful person to talk to. We sort of covered a lot last time, but we wanted to do a deep dive this month into, I think, a very interesting and vital topic. So welcome back, Shawn.
Thanks so much for having me. I'm excited to be with you again.
How are things going for you?
Things are going really well. Yeah, the practice is building up very nicely at the new Primary Children's Lehigh, and as well as at the Salt Lake office. So that's been really good. And had the opportunity to go back to Ukraine recently, did another surgical mission there, the second one in the past year. And that was very humbling, but also super rewarding. So things are going very well.
And I'm guessing some of your experiences may come to bear in what we talk about today.
Yeah.
It's interesting because as I did a little bit of background reading, I realized A, there's a whole lot I didn't know, and B, things have changed a ton over the last even couple of decades in how you guys approach the surgical problems related to spasticity, especially upper extremity spasticity. So let's just dive right back in. Before we do, have any conflicts to disclose?
Yes, I'm an educational consultant for Polynovo, which is completely unrelated to this topic today.
Okay. Well, let's just sort of set the stage a little bit. For the sake of discussion, what sorts of conditions cause the kind of spasticity that we're talking about that you address surgically?
Yeah, so spasticity is just neurologically related tightness of muscles. And there are a number of conditions that can cause that. But the one that we see the most commonly is cerebral palsy. So some type of a neurological insult around the time of birth. That's by far the most common patient presentation we see for children with spasticity. But it can also be caused by other things like traumatic brain injuries. Again, a major neurologic insult there, but that can happen anytime in life. And then sometimes we do see some spasticity associated with progressive neurologic disorders as well, which are much more rare than the other two. But things like leuko and other progressive neurologic disorders can cause it.
It does make very clear that there is a very delicate interplay and you damage any part of it and there are effects that happen. And this is where you can be so helpful. So what sorts of things does spasticity of the upper extremity cause?
So, the balance between the flexors and the extensors of all the extremities is really fine-tuned, and it's fine-tuned in the spinal cord and in the brain. And with a lot of inhibitory neurons in the CNS. And so when you have some type of insult there, you get a loss of that inhibition. And so what happens is muscles become very tight and out of balance. So for example, the most common posture in cerebral palsy for the upper extremity is to have a flexed elbow, somewhat of an adducted shoulder, and then a bent wrist, flexed wrist, that's in the pronated position. And then the fingers can also be tied into flexion as well as the thumb. And so again, flexors are always quite a bit more strong than extensors. And so they take on that sort of flexed posture. And that can be problematic, as you can imagine, for a number of reasons, even just simply putting clothes on and bathing, let alone doing functional activities of the upper extremity.
Surgeons have been trying to assist in this problem for a long time. And the thing that was striking me in looking at this is that the goals have changed progressively over that time. You want to give us just sort of a brief overview of how surgeons have addressed upper extremity spasticity?
Yeah, it's like you said, it's really been an evolution. And there are many things that were tried early on that at the time, the technology wasn't there to make it an effective treatment. And some of those have resurfaced. But what's interesting is spasticity surgery has largely focused on the lower extremities. And that's to help children be able to walk that couldn't walk, or those that can walk some to walk more efficiently. And the upper extremity, to be honest, has been a little bit neglected, the treatment of spasticity from a surgical standpoint. So the things that have come a long way are things such as moving tendons around in what we call a tendon transfer, where you can take some of these really tight flexors and you can move those around to become extensors to create a little bit more balance. So that's something that has really progressed over the last 30 to 40 years. And then the newest surgical treatment involves really mimicking one of the most common medical treatments. And that is, we use these neurotoxins like Botox or Dysport very frequently for spasticity to just relax those muscles. And now we have a way to do basically permanent Botox of the muscles by doing something called a selective neurectomy, where we can go to the little nerve branches that go right into these tight muscles, and we can just take away typically 75 to 80% of those little motor branches to the muscle, and it gets the same effect as Botox, basically a permanent weakening of that muscle. So those are at least two of the more innovative procedures that we're doing more and more now for the upper extremity. And all of these things we also do for the lower extremity also.
Two things occur to me. One is, why do you think that the upper extremity was neglected for a while? Is it just the complexity, or is there some other reason?
I think that's part of it. I think it is the complexity. I think that many of these children, just getting them up and walking, right, has taken priority of doing fine surgeries to try to increase function of the upper extremities as well. And so I think part of it is that, and part of it is just that, so many things were tried early on that didn't work very well, that caused recurrence of the spasticity later. And so I think that's another reason why some of the surgical treatments of the upper extremity fell by the wayside. But we're in a new era of medicine, of super subspecialization. And so now more than ever before, we have specialists like myself who focus on these tiny little things, right? Like my focus is pediatric hands and upper extremities. And that's about as subspecialized as you can get, to be focused like that now. And so it gives us the ability to focus on these things, to learn more about these things, and to study our outcomes closely, and to innovate and create advancements in these fields.
So a combination both of the complexity of the function and also of being able to do enough of this to be able to specialize in something that's very particular.
Yeah, that's exactly right.
It's interesting because as you were discussing what happens to an extremity, it does seem that in the past, a lot of the goals were even just to relieve both the cosmetic concerns of the way you look when your neuromuscular system is out of balance, but also the discomfort that's related to that.
Yeah, so there's a lot of treatment principles that you mentioned there, and they're all important, right? So if we think about most severely affected children, they don't have a lot of active or volitional movement of these tight muscles. And so for the most severe, it's just like you said, it's how do we decrease the pain associated with being stuck in one position all the time? And then next, how do we make this appear a little bit more normal? And then finally, as patients are able to have their limbs in a better position, can they now function a little bit better as well? So those are all, again, very good focuses of our treatment goals. And then, sometimes it's simple too. It's just hygiene. We need to be able to open this palm up to wash the skin just so they don't get infections and things like that in the palm, or to just put clothing on, So there's a lot of reasons why we treat patients with spasticity. And again, our goals change a little bit based on the severity of their baseline condition.
I would guess both based on the severity and what expertise is available too.
Yeah,
But if there's something if there's something that fits a particular need, then you're more likely to be able to address that particular need, which I think sort of leads me into my next question. Surgery obviously becomes then one of the tools in a large toolkit. It seems to me that this is one of the paradigms of an area where a team approach is absolutely vital.
Yeah, that's exactly right. I cannot do almost any of the things that I do in isolation without a really good therapist to help after surgery and sometimes even before surgery. But I also rely heavily on my neurology colleagues, right, for getting the appropriate diagnosis and then sending me patients and collaborating with those patients. Likewise, we have a really close working relationship with the pediatric orthopedic surgeons, right? Because they treat a lot of these patients, particularly their lower extremities. When it comes to musculoskeletal procedures, at least, we still, as hand surgeons and plastic surgeons and sometimes neurosurgeons, do the nerve type procedures for the lower extremity as well. But it's really an important group that we all get together and discuss how we can help these patients gain a little bit more independence and function.
And of course, putting in a pitch too for the people like me who try to put this all into context and, take care of the whole patient in the context of a family, that this collaboration, knowing your skill set, knowing what everyone brings to the table makes my job much more meaningful because I know who to reach out to. I know who to collaborate with.
Oh, absolutely. I'm glad you mentioned that, right? Because it really starts with the pediatrician. And the more pediatricians know about these newer treatments, the more they can send patients to the right places to get this done. And many of us, we get so stuck in our own little realm, and sometimes we forget to look outside of our specialties at some of the other great things that are happening. And so that is absolutely critical. And that's why I love your podcast so much, right? It's reaching out to all different levels of pediatric providers to inform them on these great new innovative procedures and options.
From a selfish point of view, when I'm curious about something, I get to ask really smart people like you questions and say, wait, that's a thing, which is kind of wonderful. So, yeah. So, are there any misconceptions or myths about what can be done surgically?
Yeah, another great question. I think we're just in this new era, and one thing that we have learned over the years is if we, for example, we have a child that has a spastic upper or lower extremity, and if we focus only on musculoskeletal procedures, for example, we can lengthen a muscle that's too tight or partially release or completely release a muscle that's too tight. One thing that we know is as that child grows, that spasticity is going to return. And for example, there's going to be scar bridging that muscle release. And eventually with growth, since those muscles that are tight don't grow as quickly as bones do, there's recurrence. And so I think that has been a little bit discouraging to patients, to parents, and to primary care providers in this realm for many years. And that's where I think doing some of the newer innovative procedures can help. So for example, if I have a very severe spastic upper extremity, if I do just musculoskeletal procedures, then I expect there to be some recurrence. But if I can do the nerve selective neurectomy procedure as well as some musculoskeletal procedures, the thought is the recurrence is much less because now we're getting a little bit more toward the heart of the problem by taking away some of the nervous input and adding that to what we've already done in the past with the musculoskeletal procedures. So I think one of the misconceptions is just that there's a high recurrence rate with surgery. So maybe we should hold off or not do surgeries early. But now with what we're doing, I think it's better long-term outcomes with these combined procedures.
And bringing me to another of my questions, it also seems from what you're saying that timing is of the essence, that thinking about things earlier than later probably has an accumulative benefit for the patient.
Yes, and it really does. The hard part is we don't know exactly the best time to start intervening yet. That's something we're still studying closely, but we know that the more spastic muscles that are present during growth, the more long-term abnormalities there are on the musculoskeletal system, right? So growth is restricted, and that can have even harder long-term challenges that we don't have as good of solutions for. So, my hope is always that I start seeing these children when they're fairly young, 5, 6, 7 years old, and even younger sometimes just as a consultation. But then, what we can do is before they start to get those really big growth spurts, we can start to relax these muscles at an earlier age That lets the skeleton grow better, gives a better long-term posture. And sometimes we do have to do some touch-up surgeries after they've gone through these growth spurts to re-lengthen muscles and tendons and so on. But I think getting to see these children earlier is certainly beneficial from a growth perspective.
Without knowing a whole lot, it would seem that a lot of the bony issues could be alleviated too if you had a chance to balance the tension earlier than later.
Yeah, and it's certainly not all bony issues, right? Because just having neurologic disorders affects bone growth as well. But certainly having a better balance of the muscular system can help things at least grow more normally.
Just put a human lens on it. Are there any particular cases that stand out for you as things that have really affected the way you look at this?
Yeah, absolutely. Again, we can categorize patients a little bit in my mind into very severely spastic patients and then less severe spastic patients that have more function at baseline. And so I'd like to give maybe an example of each of those. One case of a very severe spasticity that I treated that comes to mind was actually an older child. He was about 17 years old by the time he got to me, but I think he had a car accident at about 14 or 15 and had a severe traumatic brain injury and hemiplegia that resulted from that. And so he had a very spastic left upper extremity and left lower extremity. And we teamed up together with pediatric orthopedics who really focused on the lower extremity, and then I focused on the upper extremity. And this child was so tight, both from a shoulder adduction perspective. His elbow was completely flexed, greater than 90 degrees, wrist flexed about 90 degrees, and then fingers tight. And it was so tight that, again, his caregivers just couldn't even get clothes off and on very easily, let alone wash his underarm and his antecubital fossa and so on. Something like this is a sort of staged approach. We can't fix the whole upper extremity in one go. And so we often stage it in 2 or 3 operations, but I started by relaxing his really tight pectoralis muscle and his biceps and brachialis muscles. So I did a couple different incisions for that, but I did the selective neurectomy of the musculocutaneous nerve to take away about 80% of the nerve branches going to those elbow flexors. And then him, because he was so tight at the same time, I then lengthened his biceps tendon and his brachialis muscle. And then I partially released his pectoralis muscle. And that was our first step to just relax and get his elbow much straighter and be able to relax the shoulder a little bit. And then we came back in another stage for him. And because his wrist was so flexed, we actually did a wrist fusion on him. So we removed some of the carpal bones, straightened his wrist, released some of the tight wrist flexor muscles, and then just fused his wrist to be in a more neutral position. And then did some selective neurectomies of the finger flexors and the thumb thenar musculature to just relax those fingers, as well as some tendon transfers, and got this child from having this very tightly contracted arm to having a much more relaxed arm that then was a lot better for bathing and clothing. And again, so not a lot of function in that upper extremity because that was a very severe case.
But a lot more dignity, right?
Absolutely. Yeah.
As the human element.
So.
Yeah.
You can just imagine going from having your arm completely contracted up your day and night to having something much more relaxed. It allows for a much more normal appearance. He does have some scars, so every area where we go in, of course, is going to have a scar to it, but thankfully they all healed fine. They tend to fade away with time. I didn't personally do anything with the lower extremity, but my pediatric orthopedic partner did a number of muscle and tendon lengthenings there too to help relax that. And just help this child out tremendously in many ways, but again, not necessarily completely functional with that upper extremity. In contrast, we have patients that have more mild hemiplegia, like cerebral palsy kids that do have some flexion of their fingers, some volitional flexion of the elbow. And in those cases, again, we're aiming for a slightly better position. But for example, when you have your wrist flexed all the time, you can try it yourself. Your grip strength is extremely weak. And just moving from a flexed wrist to a slightly extended wrist your grip strength goes up tremendously. And so even just doing some simple tendon transfers, as well as some selective neurectomies to relax these tight muscles, we're able to get much better grip strength and therefore better function of the hand that way. And so on these children who are more mild, then we're aiming again for an even higher mark of better appearance, better position, better posture, all that. But we're also looking for better flexion extension of their fingers and their thumb, and allowing them to now do things bimanually that they weren't able to do before.
Yeah, that's tremendous. Yeah, it's fascinating. So obviously we have more to dive into. So over the next 2 weeks, we'll talk about some evaluation and individualization, and then hopefully maybe talk a little bit about projecting toward the future. Anything else we ought to know about putting this into a context now?
No, I think maybe what I can do is just mention a little bit more about the lower extremities and some areas where we've been able to make a pretty big impact there too. So, we see a lot of children who have very tight hip adductors, or adductor longus muscle, for example, and gracilis on the medial thigh, to where, again, it's hard to bathe, it's hard to clothe them. When they're really young, it's hard to even do diaper changes. And then when they start walking, they have this scissoring gait where one foot scissors over the other as they're trying to walk because these tight adductors. And this is another area where we have done a lot of work with the selective neurectomy procedure. And so oftentimes these patients, the standard procedure is to go in and just release their adductor muscles, but they have a very high recurrence rate. So 2 or 3 years later, they're having to have the same procedure done again. And so what we have learned is if we release those tight muscles, but also do a selective neurectomy of the obturator nerve, there's a little interior branch that goes right to those muscles. We remove the majority of that nerve, leave maybe 10 to 20% of that nerve behind. That just leads to a much lower recurrence rate. And so something simple like that is another area where, again, newer procedures can help make the older procedures more efficient. And then we can do something very similar with the hamstring muscles and the nerves going to the hamstrings. And then the heel cord as well. We can go to the tibial nerve that goes to the gastrocnemius and the soleus muscles that makes that heel cord very tight. We can also use selective neurectomies there and help relax those.
Essentially like a long-standing surgical Botox treatment.
Yeah, that's exactly right. I think that's the easiest way to think about it. And we can get into more details. There's different points along the nerve path that we can do this that are more and more selective, even to the point of what we call hyper-selective. But anyway, this is really one of the newer and latest innovations in spasticity surgery. And we just have such a great team to do this at Primary Children's Hospital and at the University Hospital for adults with strokes and things like that. For example, one of my neurosurgery partners, Dr. Mahan, who's been innovating in this space for a number of years, does a really good practice for adults as well during this.
This is great. Well, thanks so much for your time today. I know that people will have questions. Please send your questions to questions@vcurb.com, and we'll deal with those in a couple of weeks. Dr. Mendenhall, thanks for coming back, and we'll talk to you next week.
Thanks so much for having me. It's great being with you again.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who also composed the theme music. See you next time.